Hello, everyone. Our topic today is about constipation and the pain management and palliative care. These are the objectives. Prevalence. Constipation is a common symptom in the palliative community, and in fact, it can exacerbate symptom burden and distress. Constipation could be idiopathic or functional. As well, it could be related to medical condition. The median prevalence of constipation has been found to be 16% in adults. And for those above 60 years old, around 33.5% and up to 50% of nursing home residents. The prevalence of chronic functional constipation, this is what we say, basically of unknown cause or idiopathic, ranges from 2 to 27%, which is really a huge number if you think about it in the general population. And thus, you might see these patients in the palliative setting. Burden. There are estimated 2.5 million physician visits and 100,000 hospitalizations annually for the treatment of constipation. Also, there is an annual estimated expenditure of at least $800 million in the United States for laxatives. I mean, this is a huge number. $800 million just for laxatives. In a prospective study, hospice patients taking strong opioids, 87% of these hospice patients required laxatives, while 74% on weak opioids required laxatives. Still a huge number. And this gets us to an important aspect here, that once you start the opioid, you should start the laxatives at the same time. Definition. Constipation is a clinical diagnosis characterized by stool infrequency, incomplete elimination of stool, or difficulty passing stool. There can also be hard, lumpy, small stools accompanied by abdominal discomfort, bloating, distension, and pain. Normal stool frequency can be present with a minimum of one stool 3 times a week or daily. Chronic constipation is defined by using the Rome 4 criteria, which has a diagnostic sensitivity of 72% and specificity of 93.6%. Rome 4 criteria: recurrent abdominal pain on average of at least 1 day per week in the last 3 months associated with 2 or more of the following. First, related to defecation. Second, associated with a change in stool frequency. Third, associated with a change in stool form, appearance. Criteria should be fulfilled for the last 3 months, with the symptom onset over 6 months prior to diagnosis. Another important chart here is what we call Bristol stool chart. Remember in the diarrhea presentation, we said, starting 5 till 7, you start to get diarrhea. 3 and 4 probably the norm, and 1 and 2 are basically constipated patients. Types of constipation. So again, we have functional constipation, which is basically idiopathic. These patients have normal transit, and this is the commonest type of constipation, characterized by normal stool frequency but with hard stools. Then we have something called slow transit constipation, which is defined as infrequent defecation due to prolonged stool transit in the colon and can be a result of neuropathy, a smooth muscle dysfunction, or both. I mean, it's very important to pick up these patients because these need a higher level of intervention, the ones with slow transit constipation. Then we have secondary constipation. These are the ones related to different, medications, illnesses, mechanical obstruction, the type of diet, or psychosocial factors. Then we have another type, which is called the outlet constipation, which is basically a kind of pelvic floor dysfunction. And it's as a result of this coordination of the pelvic floor muscles. And these cases, guys, are not treated with laxatives. Please be careful about this. These are treated with biofeedback techniques. Okay, so you have to really differentiate between the different types of constipation so you can treat them correctly here. All right, we're going to talk a little bit about opioid induced constipation because this is a common thing that we see in both pain management and palliative care. Opioids are known to affect GI motility and the secretion via suppression of the neural activity. The opioids reduce the peristaltic movement and it increases the circular movement, okay, and reduces the secretion. So the stools become pretty hard and, we're not able to, move it. Uh, Up to 40% of patients taking opioids for non-malignant pain experience constipation. That's a big number. And 90% with malignant pain on opioids experience constipation. Opioids affect the whole GI, starting from the esophagus till the anus. Okay, so and I mean it can cause like this motility in the esophagus and give you like achalasia type picture. Can give you dysphagia, heartburn, reflux. It can cause gastroparesis in your stomach. So early satiety, heartburn, reflux, nausea, and so forth. You can go through the whole GI. The opioid receptors are abundant in the GI tract, and thus, it affects the whole GI tract, and it can cause something called opioid, gut dysmotility syndrome. Uh, In a meta-analysis that included randomized controlled trials of opioid therapies in patients with chronic non-cancer pain, opioid-induced constipation was identified as the most common side effect, 41%. Remember, we just mentioned this early on. The incidence of constipation, in non-malignant patients is that are taking opioids is around 40%. All right, causes of constipation. Again, it could be related to associated conditions, such as a depression, for example, irritable bowel syndrome. It could be related to neurologic conditions. We see it a lot. We see constipation a lot in neurologic, conditions, such as Parkinson's disease, um, dementia, spinal cord injury, autonomic neuropathy, Hirschsprung disease, and others. Medications, antidepressants, like TCAs in particular, calcium channel blockers, and anticholinergics in general can cause constipation. Structural abnormalities, we just talked about, pelvic floor dysfunction, for example, fecal impaction, mechanical obstruction, malignancy related, anal fissure. It could be related to the diet, like patient has anorexia, dehydration, low fiber intake, metabolic causes like hypercalcemia, motility abnormalities such as scleroderma, immobility, endocrine conditions such as hyperparathyroidism, constipation in cancer patients. Cancer, like intra-abdominal pelvic cancer, can cause constipation, hypercalcemia, cord compression. All of these are related to cancer. Cancer-related constipation, autonomic neuropathy, athenia, pain, dyspnea, paralysis, bed rest, delirium, and so forth. Coincidental, prior to laxative habituation, hemorrhoids, diabetes, and others. Assessment. Constipation can be associated with a variety of different causes. It's very important to get a good history from the patient, to know what kind of medications he's getting. Now, constipation in itself has its own complications, including, discomfort, including urinary retention from impaction, nausea and vomiting from obstruction, or even constipation can induce delirium. The type of constipation, you know, of a patient may be experiencing can be assessed in the context of self-reported history of bowel movements, including the frequency pattern, the characteristics of these bowel movements, volume, consistency, straining, sensation of incomplete emptying, medication use, or manual manipulation. There's another subset of constipation. It's called overflow diarrhea. This is very serious problem. You can get a leak around the fecal, mass in your bowels, and you can get diarrhea. Of course, if you treat it as diarrhea, you're gonna make it worse. So you gotta be careful. This is should be treated as constipation, not diarrhea. Physical examination. Of course, you need a thorough physical exam. Do an abdominal examination. Look for distension, tenderness, firmness, and at times a fecal mass can be palpated in the left side of the abdomen. I want to mention my own experience here. Since I used to cover the acute pain service in particular, at King Fahd. A lot of times they call you for because pain is getting worse in the post-operative period. Okay, if you're not really, paying enough attention, and you go and assess the patient might not be complaining of pain at the operative site. The patient might be complaining of constipation or urinary retention from the opioids. So you need to go there and assess by yourself the patient and see what's going on. I've seen it so many times. And the solution is to treat the constipation, not to give more opioids. Okay, there's an investigational screening system called the Leach scoring system. I'm not using it, but seems like reasonable and pretty simple to use. And in this system or the scoring system, they divide the abdomen into three regions. The first one is the ascending and proximal transverse colon. The second part is the distal transverse colon and descending colon, and the third part is the rectosigmoid. And then they score from 0 to 5. If you score more than 8, this is diagnostic for constipation. So this is how it looks like. Leach scoring system, one of the well-studied scoring systems for constipation. I don't see why not we start to apply it in our practice. Management of constipation. Well, the primary focus is to relieve the discomfort. Okay, because this is part of pain and palliative care is to relieve discomfort. Second focus should be achieving a soft formed stool without straining, with the desired frequency for 3 times per week. The third focus, and I want to stress on it, to make sure that if the patient has a fecal impaction, that it should be addressed. Now, we start, dealing with constipation by behavioral adjustments, also positioning, teaching the patient how to sit, in the toilet. Also, privacy plays an important role, especially patients that are inside the hospital. A lot of times, because of lack of privacy, they're not able to have, a normal bowel movement. So, this is the correct positioning, especially for constipated patients. Okay, having a foot rest, put your elbows on your knees, bend a little bit forward, and this is basically a very important position for you to have an easy, without strain sort of bowel movement. Okay. Also, dietary changes: increase your fluids, increase your fiber. Prawns are very useful. Okay, this is something I do myself all the time, having prawns at home. When I have these constipation issues. Okay, also you have, as I said, pick up the slow transit constipation because this needs an advanced gastroenterology consultation here. All right. Medications used for constipation. I really put a lot of effort in this slide. I kind of wrapped up all the medications because there's so many in the market right now. We have bulk forming agents, and these are not favorable in the palliative setting. You might use it in pain management, like regular pain management patient. You can always use bulk forming agents, but not palliative, not palliative care. Remember that. Stool softness. There's a lot of question mark about this stool softness right now in the literature, and some people they're not really. There's some research that it doesn't help that much. Osmotic laxatives, like polyethylene glycol, one of the commonest agents used all over the world, lactulose, especially in liver disease, sorbitol, magnesium citrate, stimulants laxatives that like bisacodyl, senna, sodium picosulfate, and glycerin, prokinetics like metoclopramide, and now we have this new drug, procalcipine, opioid antagonists. Okay, we call them the PAMORs, the methylnaltrexone and naloxegol. Intestinal secretagogues like lubiprostone, it's under the name of amitiza, and others. Inhibitor of ileal bile acid transporter, and this one is still investigation. Suppositories. I remember at King Fahd we used to use this combination all the time, glycerin and bisacodyl suppositories. Enemas. Okay, fleet enema is contraindicated in dialysis patients because it has a high phosphorus, content. Probiotics is very useful, and antispasmodics like peppermint oil. Okay, some practice points for palliative care. In the palliative setting, bulk forming agents are not preferred because these patients are dehydrated to begin with, and this could be can make it worse for them to pass a bowel movement. Okay, um, also, patients suffering from slow transit constipation or opioid induced constipation, these bulk forming agents can worsen the condition. Instead, we recommend in palliative care to start with a stimulant laxative or osmotic laxative and titrate until achieving a soft bowel movement without straining. Using two different medications from different classes is commonly needed to achieve the desired effect. Also, if you're unable to produce bowel movements with oral medications, rectal interventions such as suppositories, enemas, or manual disimpaction might be needed. Patients who require pain management with opioids should be started simultaneously on a stimulant laxative and titrated to prevent constipation. In the cases of opioid induced constipation, you can use something like methyl naltrexone. All right. And at last, magnesium citrate and fleet enema, which is high in phosphorus, are contraindicated in renal failure patients. I kind of wrapped these for you guys to give you the most important points that you need to come out of from this presentation here. Okay, we'll talk about different agents one by one right now. First, bulk forming agents, we have the psyllium, methylcellulose, and polycarbophil. And again, this is not useful in palliative setting, but could be useful in pain management. Okay, patient is a normal patient taking enough fluids. You can try to use that. You can ask him to increase his fiber intake, but not in palliative setting. And these are just some examples. Stool softeners like Ducosate and mineral oil. And as we said, in a recent review, Ducosate was shown to be no better than placebo in decreasing symptoms of constipation. I use it all the time, the Ducosate. I think it helps, especially when you use it with a stimulant. But I'm just giving you what's there in the literature right now. I think if you use it in a combo fashion, it does help. That's my own opinion, just personal experience. Okay, mineral oil, and this is Ducosate sodium. Osmotic laxatives, these are very important in practice, like the polyethylene glycol, lactulose, sorbitol, magnesium citrate, and magnesium hydroxide. Okay, and we said that the magnesium citrate and hydroxide should not be given in dialysis patients because of, might cause hypermagnesemia, and could be fatal, by the way. So this is some of the osmotic laxatives in the market. I like lactulose. It's pretty cheap, and it's just some people cannot tolerate the taste. It's a little bit sweet, but you can use always lactulose. Stimulant laxatives. You have bisacodyl, senna, and sodium picosulfate and glycerin. So again, these are very useful in opioid-induced constipation. And as they say here, it might be beneficial to take it 30 minutes after meals to augment the gastrocolic reflex. There is a strong evidence that the use of stimulant laxatives is safe and effective. I want to mention something here. We're going to just go through it. So you have senna, you have bisacodyl, you have Dulcolax. Okay, these are so famous. Available everywhere in the world here. But I want to say something, just like, side note. Okay, it's been shown that senna can cause something called melanosis coli, which is basically a condition associated with lipofuscin, not melanin, although it's called melanosis, deposition in the lamina propria. And there was some debate that this could be causing malignancy in the long term. This stuff is now out of our way, and melanosis coli, it's been shown it's not associated with an increased risk of colon cancer. So Senna is safe. Okay, I just want to, just in case if it comes through in your studying here. This is melanosis coli. It's just a deposition of a pigment. Okay, prokinetic agents. The most famous one is the metoclopramide and its cousin called domperidone. Okay, now metoclopramide antagonizes the D2 or dopamine 2 receptors and favors the acetylcholine release from the myenteric plexus in the upper GI tract. Domperidone has an advantage of metoclopramide that it doesn't cross the blood-brain barrier and thus causing extrapyramidal symptoms is much less than metoclopramide, which is the main side effect of metoclopramide is causing these extrapyramidal symptoms. Okay, Pren, very famous in Egypt here, metoclopramide, and there is actually, an IV form of metoclopramide, as you know. Mutilium or domperidone is another nice prokinetic with less side effects than metoclopramide. Okay, there's another, by the way, prokinetic we're gonna go through right now. But I didn't put it with these two because these work on the dopamine receptors. Suppositories and enemas, we talked about glycerine suppository, which is a stimulant and bisacodyl. And we have enemas like mineral oil enemas and phosphate enemas like the fleet enema. And we mentioned it, these should not be used in renal failure and dialysis patients. Okay, so these are glycerin, bisacodyl, and this is basically, this is another one, so saline laxative, sodium phosphate, saline laxative. Okay, lastly here, manual disinfection, sometimes needed. Okay, you have to use a lot of gel to do that, procedure. Every one of you guys should have the experience because it's going to happen, one of these days. You need to do it by yourself. Okay. Then I want to talk about the PAMORAs, the peripherally acting mu opioid antagonists. And the most two famous ones are methylnaltrexone and naloxone. I want to mention that these do not cross the blood-brain barrier, so they don't reverse the analgesia. Okay, the advantage of methylnaltrexone that there is a subcutaneous form and there is oral form. We use the subcutaneous form, very frequently, especially if you have a suspected opioid-induced constipation. These are mainly indicated for this purpose, not for just a regular constipation. It has to be opioid-induced constipation. Okay, and then this is Relistor injection. The adult dose is around 12 milligrams subcut. And then you have the naloxone, okay, 25 milligram tablet. New medications. All right, so these new medications, probably you need a gastroenterologist to approve them. One of them is intestinal secretagogues, like lubiprostone, linaclotide, and plicanitide. Okay, all of these are intestinal secretagogues. Lubiprostone is a chloride channel activator. These two work on stimulating the guanylate cyclase, and they increase the secretions in the intestine. Okay, and then you have a selective serotonin agonist. This is a prokinetic, the one that I just told you about, procaloprid. Okay, very famous in Egypt right now, and we use it a lot. But this is mainly for non-cancer patients, guys. This is not for cancer patients. And then you have the ileal bile acid transporter inhibitors. And these are basically investigation at this point here. We have another drug called uh, tinapanor. It's a sodium hydrogen exchanger transporter inhibitor, okay, increasing the sodium levels in the GI tract. And this is available and also for non-cancer up to now, okay? So this is the one that I want you to know about because really, it's very important is the procalciprine. It's a selective serotonin agonist and very safe, okay? Again, for non-cancer patients, for functional constipation, for gastroparesis, procalciprine. Okay, it comes in 1 and 2 milligram. I really learned about it when I came back to Egypt here, a few years back. Because I've seen a lot of people using it, and it's pretty effective. Okay, procalciprine 1 milligram. You start with one, and then you can go up to two. Okay, instead intestinal secretagogues, and we talked about it. This one I used a lot in the United States, but again, this is not for malignant cases. These are for non-malignant opioid-induced constipation. Okay, and then you have linaclotide and plecanatide. So Amitiza, it comes in two forms, 8 mics and 24 mics. The 8 mics is the one for people with irritable bowel syndrome. Okay, and Amitiza is basically the one we use for opioid-induced constipation. Okay, and these are chloride channel activators, increasing the fluid inside the intestinal lumen. And these the other two ones are similar, like the cousins of lubiprostone, okay? And but they work through activation of guanylate cyclase. And this one I told you about ilobixibat, ilobixibat, and this is investigation, okay? And then you have this Tina Panor, which is also used for non-cancer pain. It blocks an enzyme called NHE3, increasing the sodium in the gut. Okay. This one, as I said, investigational. This one is in the market right now. Okay, under the name of IBS Rela. IBS Rela. Probiotics is, camp therapy. It's very useful, especially the one that we have, evidence behind is the Bifidobacterium lactis. Okay, peppermint oil. It's a calcium channel blocker, so also it's a camp therapy, and you can try that one as well. Peppermint oil. Biofeedback in patients that have, dyssynergic defecation. And in these situations, they use, anorectal manometers for that condition. And as I said, these conditions, they're not treated with laxatives, guys. You're wasting your time. So you need to pick them up, in the exam and by history and exam. Abdominal massage is also very useful, especially in the long term. And this is how we do it. I love you, just, follow this, diagram. Uh, Hypnosis. It's been shown to be useful in constipation as well. Okay. And hypnosis is basically a state of relaxation. It's an awake state. It's a rapport with your unconscious. And I want to say that a lot of people have misconceptions about hypnosis. It's pretty safe, by the way. Acupuncture. I've done it once, and to be honest with you, in one of my patients, and it worked. But I'm not sure. I mean, it's like somebody that we tried everything, and So we had to do they asked me to do acupuncture. He was interested in it, so I did it, and he had a bowel movement. But this is as far as my experience goes. But there are literature, and these are the points, to use in uh, treating chronic constipation, if you're interested. Okay, now I want to wrap up the whole presentation here on the last two slides, and this will be very helpful to gather the information that we just talked about. So we'll start with the definition here. The constipation is a clinical diagnosis characterized by stool infrequency, incomplete elimination of stool, or difficulty passing stools. There can also be hard, lumpy, small stools accompanied by abdominal discomfort, bloating, distension, and pain. A careful bowel history is needed to determine the baseline and current patterns, including frequency, volume, consistency, straining, and sensation of incomplete evacuation. A patient may complain of diarrhea that might be a leakage of loose stool around an impaction. So be careful, guys. This is extremely important. Patient that's constipated and then all of a sudden he's complaining of diarrhea. There's something wrong here. This could be a fecal impaction. And if you treat the diarrhea, you're making it worse. Okay, be careful. Super careful about it. A rectal exam is essential component of the evaluation of constipation. The use of Ducosate, a stool softener, is not supported by current evidence. Okay, so we talked about this, but I told you my personal experience is when you combine Ducosate with Senna, for example, it does help. Okay, but I'm just telling you this is totally personal experience. However, also there is no clear evidence that chronic use of stimulant laxatives is detrimental or cause malignancy. Remember, we talked about melanosis coli caused by senna. Osmotics such as polyethylene glycol not only increase stool water and volume, but also increase motility. One of the important agents that we use is polyethylene glycol. Role of lubiprostone and linaclotide in palliative care, which increase luminal fluid and GI motility, similar to osmotics, require more research. So these are not yet approved for palliative setting, guys. Okay, maybe in the future we'll use them. Okay, I don't think there is a contraindication, but I'm just saying these are mainly for non-malignant or constipation. Okay, non-cancer constipation and non-palliative care setting constipation. Methylnaltrexone is a peripherally acting mu receptor antagonist, which doesn't reverse centrally mediated analgesia and might be effective for opioid-induced constipation. Okay, and then rectal interventions, including suppositories and enemas, may be important to soften and mobilize the hard, dry leading edge of stool before baseline. And before baseline oral regimens can be effective. Okay, and we're done, guys. Thank you so much. We have just a few seconds here. Uh, thank you. I'm gonna stop this share.